let's start with a case. So a 60-year-old female, she last seen normal at 7:30 in the morning. And her time of arrival at the hospital was 8:15, and she had a stroke scale of 10. So this is her non-contrast head CT, just showing that there's a hyperdense MCA sign there on the right side, and here's the CTA corresponding to it. Just showing the cutoff there at both ends, but there is filling past it, which is good for her. It might be contributing to her lower stroke scale presentation. This is the cerebral blood volume. So this is our surrogate for ischemic core using perfusion data. And then this, of course, is the mean transit time, which shows us what tissue is at risk. And so between these two, it helps us guide some therapy. So what do we do with a patient like this? So in years past, we would medically manage a patient like this. More currently, obviously, we use IV-TPA, given the patient's presentation, the fact that they're here within a certain amount of time, inside 4.5 hours from ictus. But now we're actually more commonly using endovascular clot removal, and we're going to go over the basis for why that is the practice at this point. So first of all, we should note that there's a very good data that suggests that if you can recanalize or you can open up an occluded vessel, a patient will tend to do better. And so what this slide is just trying to show you is that in those patients who do get some degree of vascularization, their outcomes are better. Obviously, modified Rankin ZERD2 is better than that which is above. And then this also then immediately dovetails to the 90-day mortality. And most importantly, at the very end there, just because you open the vessel does not necessarily mean that you're at a higher risk for having symptomatic intracranial hemorrhage. And so that's always a concern when you open up a vessel into an area that's had a stroke, is that you could get a reperfusion bleed. So this is the goal of stroke treatment as it exists today. The idea that on this top image here, you can see we have a patient who has an occluded middle cerebral artery. And then this is a post-recanalization action here. This is one of our colleagues, Joey English. And so this is some of the clot that came out of that. So IV-TPA is the gold standard. This has been around since 1996. And there's, a lot of data, level 1 data that suggests that this is really, an excellent medical innovation for patients with acute ischemic stroke. The problem with IV-TPA, of course, is that it only can really be applied in a small number of patients because of its extremely narrow time window, and the fact that given outside of that time window, your risk of symptomatic hemorrhage certainly goes up. The other problem with IV-TPA is that it's very, very limited in its ability to affect large vessel occlusions. And though this is a significant fraction of all stroke patients, IV-TPA has not done as well as for this subset as it has for other types. So this type of data that's trying to show you here. This is the probability of recanalization. And this is the length of the clot. This is based off of data from stroke in 2011. And so what this is just showing that you're more likely to get recanalization if you have a small clot burden, whereas obviously if there's a persistent occlusion and there's a large clot amount here in terms of the length, that recanalization effect drops precipitously. So as I mentioned, a significant fraction of strokes, almost 50% of them, will be considered what we call large vessel. And so these are those of the internal carotid, the proximal middle cerebral artery, and then of course the posterior circulation, the vertebral basilar arteries. And so you can see here that when you have these larger vessel occlusions, in addition to them being more recalcitrant to IV-TPA, they also carry higher mortality rates, which is not surprising, again, given the fact that how much territory is affected when you more proximally occlude things. So obviously, we've been studying stroke for a long time, and also from an endovascular standpoint, there have been a number of trials that have been published looking at the role of interventions through an endovascular standpoint. Some of these have been based off of the delivery of IV-TPA in an intraarterial fashion. Others have looked at different types of devices. The one most memorable, of course, is the Mercy device. But ultimately, a lot of these trials were inconclusive when looked at individually in terms of their ability to really affect large vessel occlusion. And part of that was the technology itself. We have better technology. We're going to talk about that in just a second. But also it had to do with how the patients were selected. And so again, our ability to better understand where vessels are occluded, which vessels are occluded, and then which patients have already had a significant injury. And then the other element, which I think I can't underscore enough, it's harder to capture, but you'll see it somewhat in the slides subsequent, is that it really has changed our ability to work as a team to understand the importance of time and how it affects stroke outcome. So this is the big technological feat from an endovascular standpoint, is the use of stent Reavers. And so this is just a picture of the Trevo device, which is made by Stryker Neurovascular. There's a comparable device called the Solitaire device, which is made by Medtronic. But what this is for all intent and purpose a stent, and these are the same types of materials and stresses that the stent would use if it were used, let's say, for a treatment of an aneurysm. But in this case, it's actually permanently attached to a wire, a delivery wire. So what this does is it allows you to cross the clot and then open the stent inside the clot itself, and this migrates into the clot and actually hangs onto it, if you can imagine, and then uncorks the bottle. And so this provides a high degree of safety because, again, these are used routinely for other parts of endovascular practice, but it also has a lot more ability to get traction on the clot itself and then remove it, as opposed to the Mercy device, which was less successful in doing so. So, and again, the other thing I mentioned was, of course, the imaging. So the Alberta Stroke Scale Score, the aspect score, is one of the benchmarks of all the trials you're about to see. And this is really the core which studied that all patients need to undergo prior to any sort of intervention, whether it's medical or endovascular therapy. CT angiography obviously is very quick. It dovetails very nicely with the non-contrast head CT, which is the first step in any sort of stroke workup. And what these multi-phase CTs now can do is give us collateral scoring. We'll talk about how some of the studies use collateral scoring to help select patients. It also gives us perfusion data, which you saw earlier, the ability to get core infarct information as well as those areas at risk, and how we're now using perfusion to help select patients for other trials. We'll talk about that. And then, of course, MR can't be underscored. MR is still the gold standard for looking at viable brain tissue, and it has absolutely has a role in stroke workup. So this is the aspect score. This is a 10-point scale, 0 being a large core infarct in the middle cerebral distribution, a 10 meaning absolutely no evidence of that. And what you do is you take data, or you take essentially a slab at a certain kind of window level to kind of look for areas of ischemia inside the basal ganglia, but also into the cortex. And based off of that, that tells you what's the likelihood that this patient could have a significant reperfusion hemorrhage based off of the size of that core infarct.